Welcome to the CCI webinar. Greetings from Chest Council of India. Good evening to one and all. First of all, I thank you very much for this wonderful opportunity. Every Thursday, we are doing the different kind of topic presentation from our Chest Council of India. I will share my screen. Today's webinar topic is parasitic respiratory infections beyond Hydatid diseases. First of all, I thank you very much. This is a dream topic of our chairman, Dr. S Krishna sir. So thank you very much, Krishna sir, for your wonderful topic every Thursday. We are enjoying. This is the academic excellence of our Chest Council of India. This is the beauty of Chest Council of India. Every Thursday is a different topic and different speakers across India. So thank you very much. I thank you, our co-chairman, Dr. Narayana Pratibha sir, and the National President, Dr. Ashish Dubey sir, National Secretary, Dr. Anil Maske sir, and CCI Webinar Coordinator, Dr. Chennai, and the other leaders, Dr. Atri Gangopatyay, Dr. Shivani Swami, Dr. Kiran, Dr. Nitin, all the leaders of Chest Council of India. So we are doing a wonderful human service to our medical fraternity. Every Thursday, we are enjoying updating our knowledge. Ultimately, we are helping this patient. So the today's topic of is the respiratory parasitic infection beyond Hydatid disease. This topic itself is a very, very important in clinical practice. This topic consists of, there are 4 highlighting points. One is the helps you to understand the complete spectrum. Number 2 is the role of immunity and eosinophils in pathophysiology. Third highlighting point is the understand the diagnostic algorithm. And fourth point is the role of interventions like bronchoscope and VATS in the management. You all know very well any infections of the pleuropulmonary region. So there are a lot of differential diagnoses, lot of causative agents to start from the viral etiology, bacterial etiology, and the mycobacterial etiology, very common in our country, and fungal etiology in an immunosuppressed individual, uncontrolled diabetic individual. And we have parasitic infections. Any infections, the treatment failure, we have to keep in mind, this is one of the differential diagnoses of the respiratory parasitic infection. For this diagnosis, we have to have the detailed history and meticulous examination and appropriate investigation to clinch the diagnosis of this kind of respiratory parasitic infections. So you all know very well about that. There are a lot of clinical presentation, lot of radiological presentation. This respiratory parasitic infection may mimic tuberculosis one end, and other end it may mimic the malignancy. In between, a lot of infection kind of things. So these kind of parasitic infection patient may present with asthma symptoms, or may present with TB symptoms, or may present with the malignant symptom. So each and every parasite has a different diagnostic criteria and different treatment modalities we have. Example, amoebiasis, we have to give metronidazole. And Hydatid, we have to give the mebendazole or albendazole. So likewise, the various drug of choice are there. So we have to meticulously, precisely diagnose and precisely treat. Nowadays, we are all in an era of precision medicine. So precise treatment diagnosis are very important to prevent morbidity and mortality. So coming to the parasitic lung disease, there are 2 major categories of the parasitic lung infections. One is the helminthic infection, other one is the protozoal infection. In helminthic infection, there are 3 kinds of worms, 3 kinds of species. One is the nematodes. Nematodes, again, it causes 5 major diseases like ascariasis, ankylostomiasis, strongyloidiasis, tropical pulmonary eosinophilia. And other species, the trematodes, schistosomiasis, and paragoniasis. And we have cestodes under the helminthiasis, we have echinococcosis. And other main category is the protozoa. In the protozoa, we have 5 major diseases. One is the amoebiasis, leishmaniasis, malaria, toxoplasmosis, and babesiosis. So these kind of infection varying presentation. In general, the pleuropulmonary manifestation, radiologically, it can show variety of presentation. Focal lesions and the diffuse lesions. In focal lesions, we have a cystic lesion, coin lesion, pleural effusion, and consolidation catheter lesion. In the case of diffuse lung disease, you can see as a transient pulmonary infiltrate or alveolar interstitial lung disease pattern. So a lot of clinical and radiological differentiation we have to keep in mind. The high index of suspicious are very important. to clinch the diagnosis of the respiratory infection caused by this kind of a parasitic infection. So with this, we are going to enter into the webinar program. We have a wonderful star speakers and panelists today. I am Dr. S Jayaraman, moderator of this today's webinar. I am the senior consultant, pulmonologist working in MGM Healthcare, Billroth Hospitals and Apollo Hospital in Chennai. I have my own clinic, Sri Jayam Chest and Sleep Clinic in Chennai. My area of special interest is the interventional pulmonology and sleep disorder breathing. I'm the secretary of Indian Medical Association, Academy of Medical Specialties, Tamil Nadu State Branch. I'm the chairperson of MGM Academics. May I introduce our speaker, elite speakers, panelist, Dr. Kulbir Singh Chopra, MD with the gold medalist from Dr. SN Medical College, Jodhpur, Rajasthan, from 2004. And sir is the Kulbir Singh is senior specialist, Department of Pulmonology, additional superintendent, District Hospital, Jodhpur, Allied Hospital, Dr. SN Medical College, Jodhpur. Welcome, Dr. Kulbir Singh, sir. Good evening. We have the other eminent panelist, Dr. Komal Shah, DNB Pulmonology with the gold medal from Jaislok Hospital and Research Center, Mumbai. He has a fellowship in infectious disease from CMC, the Christian Medical College, Vellore, in 2022, and FCCS USA from in the year of 2019. Komal Shah is an associate professor, Department of Pulmonology, working in Dr. Vasantrao Pawar Medical College Hospital and Research Center, and consultant infectious disease specialist, Ashoka Medicover Hospital, Nemco Hospital from Nashik. Welcome, Dr. Komal Shah. And may we introduce Dr. Bhushan Thombare. He is a senior consultant thoracic surgeon from Indraprastha Apollo Hospital, Delhi. He has finished the DNB General Surgery from Medical Trust Hospital and DNB Thoracic Surgery from RG Kar Medical College Hospital. He has a specialist in all thoracic kind of surgical procedures like uniportal robotic thoracic surgery, uniportal video assisted thoracoscopic surgery, mesothelioma surgeries, lung cancer surgery, esophageal surgery, tracheal surgery, non-intubated subxiphoid thymectomy, diaphragm surgery, and the surgery for the pulmonary infections. So welcome, Dr. Bhushan. Last but not the least, may I introduce and welcome Dr. K. Dayanand. Sir is the civil surgeon, specialist in tuberculosis and chest diseases in Insurance Medical Services, Government of Telangana, ESA Hospital, Ramachandrapuram, Sangareddy District, Telangana. The visiting consultant in Indo-American Cancer Hospital and Research Institute, Banjara Hills, Hyderabad, and Apollo Hospital, Secunderabad. So welcome, Dr. Dayanand, sir. I welcome all the esteemed panelists across the India. So with that, we'll start our program. The flow of the event will be, there are 3 continuous presentations. The first speaker is Dr. Kulbir Singh, followed by Dr. Komal, and followed by Dr. Bhushan, sir. So after the 3 presentations, so we'll have a panel discussion and the questions discussion from the chat box, etc. So now may I request the Dr. Kulbir Singh, sir, to present his topic on helminthic infections, helminthic parasitic infection, respiratory infections. Over to Dr. Kulbir Singh, sir.
Topic of my presentation is parasitic respiratory infections of lung beyond hydatid diseases. Myself, Dr. Kulbir Singh, pulmonologist from Jodhpur. Parasitic infections of lung usually associated with unsafe water, poor sanitation, poor living condition. These infections affects approximately 2 billion people in tropical and subtropical countries of the world. Tropical parasitic lung disease include mainly nematodes, trematodes, and cystodes. In nematodes, usually pulmonary ascariasis, pulmonary ankylostomiasis, pulmonary strongyloidiasis, tropical pulmonary eosinophilia are seen. In trematodes, pulmonary schistosomiasis, pulmonary paragonimiasis, and in cystode, pulmonary hydatid cysts are common. Tropical parasitic lung diseases will be discussed separately. Loeffler syndrome, it will be discussed later in later slides. The pulmonary lesions in helminthic diseases of lung include cystic lung disease, consolidation, pleural effusion, transient pulmonary infiltrate, pulmonary nodules, and abscess and alveolar interstitial involvement. First, we will discuss Ascaris lumbricoids caused by the ingestion of the embryonated eggs of the Ascaris lumbricoids in the fecal contaminated soil. Pneumonia may occur in 1 to 3 weeks after the primary infection. Pathology includes increased secretion of mucus by bronchial wall and serous discharge in the alveoli and patch inflated around the larva in the lungs. Pathogenesis, ingestion of eggs which hatch in the gut, then they penetrate the gut wall, reach right heart and lungs via venous blood, reach trachea and swallowed, reach small intestine, and then develop into adult worm. Hookworm and strongylitis. In immunosuppressed individuals, they are more common, leading to increased infection. Pulmonary manifestations include alveolar hemorrhage, bronchopneumonia, chronic bronchitis, bronchial asthma, heavy infection with strongylitis associated with gram-negative bacterial infection carried from intestine. Mortality is around 87% in hyperinfection syndrome. Pathogenesis, infected larva penetrate skin, reach lungs via blood, reach alveolar space, then reach trachea and swallowed, reach small intestine again and develop into adult worms. Loeffler syndrome is common in Ascaris, in which hypersensitivity response occurs 1 to 3 weeks after the infection because of the migration of larva through the lung circulation. Symptoms are cough, shortness of breath, hemoptysis, chest pain, and fever. And transient the infiltrates are seen in chest X-rays. Ascariasis and hookworm management. The tablet albendazole 400 milligram given OD or tablet mebendazole 100 milligram OD for 3 days. And the strongylitis management is ivermectin dose for 2 days, which is according to the weight band shown in the diagram. Diagnosis, stool examination is usually negative. Management, symptomatic, antihelminthic drug ineffective at this pulmonary stage. Serology is indirect hemagglutination assay, eosinophilia seen, and demonstration of larva and sputum is there. Then comes the visceral larva migrants. This life cycle is similar to the Ascaris lumbricoids, caused by the ingestion of the embryonated eggs of the nematodes, parasitic animals. More common in children below 5 years of age, which usually live in overcrowded places with poor sanitation. Organisms usually are Toxocara canis, dog roundworm, Toxocara cati, cat roundworm. It mainly affects liver, lung, and other organs. Diagnosis is by the ELISA TESAG, followed by the Western blot. Treatment is albendazole and steroids. Tropical pulmonary eosinophilia is caused by Wisteria bancrofti. Features are history of residence in filaria endemic area. Paroxysmal nocturnal cough is there. Eosinophilia positive serology in a response to DEC treatment. Trapping of filaria in the reticuloendothelial tissue causes lymphadenopathy, hepatomegaly. In the absence of treatment, it can cause interstitial fibrosis in lungs. Differential diagnosis is asthma, Loeffler syndrome, allergic bronchopulmonary aspergillosis, Churg-Strauss syndrome, and systemic vasculitis. Diagnosis, chest X-ray, usually miliary and normal pattern may be seen. Serum Ig is raised, anti-filarial antibody raised. Spirometry, restrictive pattern is seen, and treatment is DEC 4 to 6 milligram per kg body weight for 14 days. Tablet doxycycline 100 milligram BD for 14 days, which kills the Wolbachia bacteria, a symbiotic bacteria. This bacteria causes the increased multiplication of the worm, especially the female worm, which gives more eggs when this bacteria is present. So there is a symbiotic relationship between this Wolbachia bacteria and the worm. When the doxycycline kills this Wolbachia bacteria, the multiplication and of the worm is decreased, and patient is cured much better way. Schistosomiasis, they are blood fugues. Man get infected by penetration of the skin by Cercaria. Cercarias are the cystosobula and ultimately reach pelvic, venous, and mesenteric plexus. And Cystosome X may reach the lungs, which can cause the lung disease. These X can reach small arteriole of the lungs, where they can cause delayed hypersensitivity. This may ultimately lead to pulmonary hypertension and cause pulmonale. Common symptoms are cough, dyspnea, fever, chronic infection can lead to cor pulmonale. Diagnosis, detection of X in stool, urine, and PCR serologies can be done. Hydatid disease caused by Echinococcus granulosus multilocularis. Dog is the definitive host. Man gets infected by eating food contaminated with fecal containing X. Embryos go to different locations like lungs and liver. Lesions develop into cyst called hydatid cyst, which can grow 2 to 3 centimeters per year. Inner lining of this cyst is germinal layer capable of producing daughter cyst, which can seed to other organ on being ruptured. More common in children, lesions in the lungs can be seen in early course of disease as seen by chest X-ray. Pulmonary cysts are usually solitary in 60% of cases. Mostly seen in one lobe lung, cyst is surrounded by granulomatous reaction, ultimately causing calcified mass. Spontaneous rupture of cyst into the bronchus by expectoration of scolex into the sputum, while rupture into pleura can cause pleural effusion. Fluid contained in cyst is immunogenic, which can cause anaphylactic reaction. Clinical features: cysts are usually asymptomatic. Other symptoms are cough, dyspnea, chest pain. Differential diagnosis: asthma, Lafleur syndrome, allergic bronchopulmonary aspergillosis, Churg-Strauss syndrome, systemic vasculitis. Treatment: surgery is the treatment of choice for the hydatid disease of the lung. It will confirm the diagnosis. Enucleation of the intact cyst, cystotomy, removal of the cyst with aspiration, lobectomy, segmental resection can be done. Pair: it is percutaneous aspiration, injection of cysticidal agent, and re-aspiration are not recommended now for lung cyst. Immediate thoracotomy is recommended for patients who have rupture of hepatic cyst into pleural space. Tablet albendazole 400 mg BD for 28 days if all the cyst cannot be removed or when rupture of cyst has occurred. Thanks.
Good evening, everyone. First of all, I would like to thank CCI for giving me this opportunity to present my presentation on this huge platform. Thank you, Jayaraman sir, for the kind introduction. And thank you, Kulbir Singh sir, for this excellent presentation on helminthic infections in lung respiratory system. So now taking it further, I'll be talking about parasitic lung diseases caused by protozoas. So what are parasites? Parasite is an organism that lives in or on in host and gets its food from or at the expense of the host. We know all this. So they are divided into protozoa, helminths, and parasites. Now, helminths, as sir mentioned, are divided into nematodes, cystodes, and trematodes, whereas protozoas are microscopic, one-celled organisms. They are free-living or they can be parasitic in nature, and they can be able to multiply in humans. That is why which contributes to their survival, and it can also lead to serious infections from just one single organism. They can be transmitted by fecal-oral or route or by the arthropod vector. So they are further classified into 4 groups, that is Sarcodina, Flagella, Sporozoa, and Incisura. We are going to talk about Amebia, Leishmania, Plasmodium, and Toxoplasma out of all these protozoas present. So let us start with pulmonary amoebiasis. It is caused by Enterobia histolytica. It is the third most common cause of mortality amongst parasitic infection, first being malaria and second Toxoplasma. Approximately 1% of world's population is infected, with 40,000 to 110,000 related deaths reported annually. It is distributed worldwide. However, low socioeconomic status and tropical and subtropical climates are more prone to get this infection. The infection is acquired by ingestion of cysts that become trophozoites in the colon and may invade the bowel wall. We all have been learning about this life cycle since years, but once we go through it again, the motile trophozoid forms of the parasite live in lumen of large intestine, where they multiply and differentiate into cysts. Cysts are passed into feces and are highly resistant to environmental conditions, facilitating fecal-oral transmission. And then further ingested cysts are transformed into trophozoites. Amoebiasis can present as two ways. One is intestinal, that is dysentery or colitis, or extraintestinal, could be primary or secondary. And the most common one is hepatic, followed by pulmonary, cerebral, skin, or subcutaneous. Cutaneous. Now, when we talk about pleuropulmonary amoebiasis, the mechanism is first most important, direct spread of amoebic liver abscess rupture through the diaphragm, or it can spread from intestinal infection that spread to the thoracic cavity via hematogenous or lymphatic route. Primary amoebiasis can be by inhalation of dust containing E. histolytica. Presentation could vary from consolidation to lung abscess to infusion to empyema to hepatobronchial or bronchobiliary fistula. IVC invasion, it can lead to thromboembolism, which is very rare though, or pericardial effusion. Diagnosis, it is very difficult to diagnose amoebiasis just on radiological or clinical basis, so it should be a combination of clinical, epidemiological, radiological, microbiological, and serological test. So clinical features, patient presenting from an endemic area or there is history of travel to the endemic area with some specific socioeconomic background. Patient may present with symptoms of amoebic dysentery or liver abscess, but it is not mandatory in case of primary pulmonary amoebiasis. And pulmonary presentation could be fever, cough, hemoptysis, or pleuritic chest pain. Hepatic abscess may provoke venous compression, which can cause respiratory distress. And they can be purulent fluid like anchovy paste or chocolate sauce like appearance following the puncture of an abscess, discharge, or through vomiting. The radiological findings, as I mentioned earlier, could be variable from consolidation. They could be fine basal reticular patterns with focal areas of atelectasis to extensive infiltrates. They could be just elevation of right diaphragm and underlying atelectasis. So this is a case report which was presented in September 2021. This is the case of primary pulmonary amoebiasis without GI involvement. Another case of primary pulmonary amoebiasis, here it is presented as multicystic empyema and presented in 2016. Now, to further diagnose stool examination, which is very important in case of dysentery, but has limited role in pleuropulmonary amoebiasis because the cystole tropozoites are seen only in 15 to 33% patients with extraintestinal amoebiasis. Many pleuropulmonary manifestations may be even unrelated to E. histolytica. And there is high prevalence of positive stool asymptomatic carriers which can mislead to diagnosis. We can also take microbiology help by direct wet mount preparation, cultivation or staining methods. However, the important ones are immunological tests like IgG and IgM antibodies and antigen detection tests. And nowadays, PCR detection is very helpful in diagnosis of pulmonary amoebiasis. The treatment is metronidazole for 500 to 750 milligram TID for 10 days, or can be used is tinidazole plus tablet paromomycin 25 to 35 milligram per kilogram per day, divided in 3 doses for 7 days to clear intestinal cyst. The next one is pulmonary manifestations of malaria. This is also very, very important. We all know the vector is Anopheles mosquito and the plasmodium species are Falciparum, malariae, oval and vivax. This image is from the CDC, which shows that how beautifully it is distributed in the tropical countries. This is the cycle. So we all know the cycle, but we need to know that when tropozoites of P. vivax and Falciparum are released, the merozoites are released from the erythrocytes is the stage where ARDS can develop. So clinical features of malaria like fever with chills, tertiary fever, quaternary fever, sweating, anemia, leukopenia, splenomegaly is obviously present. But the pulmonary manifestations most important is pulmonary edema and ARDS. Other pulmonary manifestations include pleural effusion, intestinal edema, consolidation. Transient cough was noted in 36% of patients with P. falciparum infection and 53% of those with 5X and oval infections. This was presented in Journal of Medicine in 2005. There could be subclinical airflow obstruction and impaired gas exchange also. And very rarely, it can also present with bronchitis obliterans organizing pneumonia. This was the case report of a 31-year-old male who presented with P. falciparum malaria and ARDS. The diagnosis can be done by thick and thin smears, serology, and nucleic acid test. And there are very beautiful guidelines presented by CDC in 2023, which shows that we have to give parental artemisinin preparations in case of severe malaria. If it is not available, we can also give quinine salt. The next important protozoal infection is pulmonary leishmaniasis. Protozoa here is Leishmania donomani and vector is sandfly. Again, beautifully distributed amongst the tropics. So leishmaniasis can present as three ways: cutaneous, mucosal, and visceral leishmaniasis, that is Kala-Azar. Visceral leishmaniasis generally presents as insidious onset, prolonged fever, weight loss, and prominent splenomegaly. It can mimic tuberculosis sometimes. And pulmonary manifestations are pneumonitis, pleural effusion, and mediastinal lymphadenopathy. The diagnosis again is the combination of clinical, radiological, parasites in bone marrow and spirit, and PCR. Treatment is important to remember here. In immunocompetent hosts, liposomal amphotericin B 3 mg per kilogram IV OD on day 1 to 5, that is for 5 days, followed by day 14 and day 21, that is total 7 days, total cumulative 21 mg per kilogram cumulative dose. If the patient is immunocompromised, we have to give liposomal amphotericin B cumulative 30 mg per kilogram dose for total of 6 days, plus metafocin 100 mg per day for 28 days. And in case of secondary prophylaxis, we can give liposomal amphotericin B 3 to 5 mg per kilogram every 3rd to 4th week until the CD4 count is more than 350. The reference here is by WHO guidelines in June 2022. And last but not the least is pulmonary toxoplasmosis. Protozoa here is Toxoplasma gondii. Primary hosts are cats, and humans get infected by ingesting cysts contaminated with uncooked food. The clinical features, general features, many patients present as asymptomatic, myalgia, and generalized lymphadenopathy. However, immunocompromised host can present as encephalitis, brain abscess, or disseminated infection. Pulmonary manifestations are varied from interstitial pneumonia to diffuse alveolar hemorrhage to necrotizing pneumonia. This is a case of disseminated toxoplasmosis in a patient with advanced HIV, and which was reported in 2018. Diagnosis: visualizing tachyzoids through microscopic examination in bronchoalveolar lavage, stained by TIMSA, indirect immunofluorescence, or immunohistochemistry. We can do cell or laboratory inoculation of BAL. It can be detected by histopathological examination, antibody testing, or PCR. The treatment should be continued till 6 weeks after resolution of symptoms. It consists of pyrimethamine plus sulfadiazine plus folinic acid. So at the end, take-home points from my presentation would be: protozoal lung infections are more common than thought of. They are distributed worldwide, but more common in tropics and in specific socioeconomic status. They have varied presentation from consolidation to effusion to ARDS, and we have to keep our eyes and brains open for the diagnosis where we are not finding any other cause for consolidation or effusion. It can be diagnosed with combination of clinical, radiological, microbiological, and serological factors. And beautiful treatment guidelines are available by CDC, by WHO, and it should be followed along with the primary and secondary prophylaxis. We humans are the greatest of all parasites. With this quote, I would like to end my presentation. Thank you very much.
Thank you, Dr. Jayaraman, for the introduction. I will speak about surgeon's role in parasitic respiratory infection. Greetings from Indraprastha Apollo Hospital, Delhi. This is a case, as you can see in the X-ray, right pericardiac shadow. She was a 30-year-old lady coming with complaints of cough, underwent a chest X-ray, showed a pericardiac shadow. CT thorax showed a cystic lesion in the lung and the liver. Therefore, a screening ultrasound was done where we found out that there was another lesion in the pelvis. She underwent a CT abdomen, found to be a pelvic cyst also. You can see in these three images, in the middle image, you can see the liver cyst with the membrane seen, and the lung and the liver. The last image on the extreme right of the screen is the left of the screen is the lung, liver, and the pelvis hydatid cyst. Patient underwent preoperative workup with 2 weeks of albendazole therapy She underwent removal of the lung, liver, and pelvic cyst at the same setting. Histopathology confirmed the diagnosis. Here, in the extreme right of the screen, you can see the cyst enucleated from the lung here, and the middle image shows the cyst enucleated from the liver by incising the diaphragm. And the last extreme left image, you can see the pelvic hydatid cyst with the appendix adhered to it. The lung, liver, and the pelvic hydatid cyst completely removed. Patient was continued albendazole therapy post surgery with a follow-up protocol. These images are from our super specialty days in Arjikar Medical College. Case 2, a 35-year-old gentleman came with complaints of recurrent hemoptysis, bitter tasted sputum. He had history of multiple hydatid cysts since 2015, and he had refused surgery. He was on albendazole therapy, which was unsupervised. A fiber optic bronchoscopy revealed clot in the right lower lobe bronchus. Washings were positive for bile salts and bile pigments. A diagnosis of bronchobiliary fistula was made. You can see in the patient came in 2020, where you can see the clot in the lower lobe bronchus and the multi-septate cysts in the liver. The contrast enhanced CT exactly shows the pattern of the cyst. I will the same patient, he had come in 2015, where you can see bilateral lung cyst, which the left lung cyst was disappeared after albendazole therapy, and the liver cyst became multi-septated. Right. This is a bronchoscopy picture showing the right lower lobe bronchus with blood clot. And we did a CT angiography and bronchial artery embolization prior to contemplating surgery. This is the after preoperative optimization, he underwent a combined procedure where we did right lower lobectomy, and simultaneously the GI or the liver team did the right hepatectomy with en bloc resection of right lung, lower lobe, and the diaphragm. Diaphragm was reconstructed. The whole specimen was delivered via abdomen. The histopathology revealed Echinococcus multilocularis. The postoperative period was uneventful. The patient was discharged with follow-up protocol and albendazole therapy. When does surgeon come into picture in such cases? So surgery for primary disease, hydatid cyst, surgery for complications, hemoptysis, hemorrhage, ruptured hydatid, lung abscess with liver connection, as we have seen, not resolving, bronchobiliary fistula or empyema. What are the surgical procedures in surgeon's armamentarium? A simple enucleation of cyst, Egon's method, pericystectomy, removing the covering of the cyst, Perez Fontana method. Sometimes we have to do the cystotomy with captionage, Barrett's method, cystostomy with closure of bronchial openings, captionage Soda's method, cystostomy with closure of bronchial openings alone. But a lot of times this leads to abscess formation. The open aspiration by Figueroa technique, just like as we do pair in hepatic hydatid cyst. Sometimes you require to resect the lung. What are the pre-indications, prerequisites for lung resection? The cyst involves 50%, more than 50% of the lobe, infected cyst, not responding to treatment, multiple unilobar cysts, and the consequences of hydatid disease such as bronchiectasis, severe hemorrhage, or hemoptysis. What is the preoperative preparation required? Routine labs, especially the liver function test, imaging, contrast enhanced CT, a USG screening abdomen to look for any other cysts, fiber optic bronchoscopy to see the cyst. Sometimes you can see the cyst wall and washings for a culture. PFT, DLCO, echocardiography as a part of cardiopulmonary assessment. 2 weeks of albendazole therapy prior to planned surgery, dose 10 to 15 milligram per kilogram per day, taken twice daily. The key intraoperative care and consideration while contemplating this surgery: lung isolation, watchful for anaphylaxis, flooding of intraoperative field with 20% saline or scolicidal agent if at all any spillage occurs, avoiding spillage, complete removal of cyst, thorough lavage of chest cavity, meticulous closure of any air leak, using the proper surgical technique like enucleation, lobectomy. Bilateral cyst stage procedure can be done at same sitting. Post-surgical follow-up, this is the most important aspect while treating parasitic lung infections. Albendazole therapy, drug therapy for minimum 6 months to prevent recurrence. Risk is high as 11% if not used. The post-operative follow-up is clinical examination, liver function test, chest X-ray once in month for 3 months, then continued every 3 months till the end of first post-operative year. Other parasitic infections may present as complicated effusions, empymas, especially the amoebic liver abscesses rupturing into the thorax, or the lung fluke maybe sometimes cause effusions or empyema, which may require drainage or decortication surgery. The lung fluke or paragonismus infections would be difficult to diagnose, especially in those case. A thoracoscopic biopsy would help in establishing the diagnosis and proper treatment. The take-home message: pulmonary hydatid cysts are treated pharmacologically or by surgery. Patients with hepatic hydatid cyst or lung cyst may have coexistent other cysts as well, vice versa. 2 weeks of albendazole therapy prior to surgery. Long-term compliance and follow-up is required. You can see this is the cystectomy done, showing the bronchial air leak with bubbles seen. This is a phrenotomy for liver hydatid. Infected hydatid cyst, where the cyst excision with decortication procedure was coupled. This is a surgical video of a 50-year-old gentleman coming with hemoptysis and having a right lower lobe hydatid cyst. All preoperative workup was done, and he was planned for VATS hydatid cyst excision with pericystectomy and bronchial leak closure, where we have incised the cyst. You can see the cyst and the membrane, which were densely adherent to the wall. Here we are clipping the bleeding spot. Sometimes suturing is also required. And we are placing the betadine soaked gauze pieces, and later on the air leak is checked. You can see the bubbles during this thing. The air leak is being meticulously taken care of by suturing. You can use tissue glue also. And once everything is done, the captainage is done, the cyst wall is obliterated completely so that no dead space is there. There are saline soaked mops which are removed out of the field, and the thorough lavage of the chest cavity is done. This is the post-operative chest X-ray on day 1, where you can see the ICD is there and the right lung expanding. Thank you, CCI, for giving me this opportunity. I will hand over further to our team.
Wow. Very good, superb presentation of 3 speakers. Dr. Kulbir Singh elaborated in detail about the helminthic infections in the lung. And Dr. Komal presented beautifully about the protozoal infections, Kalaza, Leishmaniasis, etc. And our surgeon, Dr. Bhushan, so demonstrated all the indications and the contraindications of the role of surgery in parasitic infections, mainly the role in hydatid cyst, that is a cyst removal. So without removing the lung, and sometimes in the case of the bronchopulmonary fistula, we have to remove the underlying lobe, that is lobectomy, along with partial hepatectomy and the closure of the diaphragm repair, everything. So we had a very beautiful presentation of 3 varied presentations. So thank you, Dr. Kulbir Singh and Dr. Komal and Dr. Bhushan sir. We had a wonderful lot of points you mentioned during your presentation. So thank you all for this wonderful thing. So we'll move on to the panel discussion. May I request our senior consultant, Dr. Dayanand sir, to start with Dr. Dayanand. So you are all working in 3 hospitals, ESI and Apollo and the Indo-American Hospital, one of the all referral center in Hyderabad, Telangana. So what are the common parasitic lung infections you come across in your practice, and what are the modes of transmission of this parasitic lung infection? Already Komal said very clearly mode of transmission. Just your point of view, we just highlight and throw some light on your view about the common parasitic infections in your practice. Yes.
Good evening all, and a very heartfelt thanks to all my CCI family for inviting me for this webinar. Coming to the question, the first one where I work is a government setup. So generally, I get mostly in my practice so far, I have seen the predominant cases have been the eosinophilia, the pulmonary eosinophilia type. Then here and there, we do get amoebic abscesses, liver abscesses complicating into a pulmonary problem. A few of them, but in between them are the hydatid cysts, which are incidentally picked up. And in the cancer center where I work, sometimes they present as masses for evaluation. These are the three things. Then coming to the mode of transmission of the parasitic lung diseases, as Komal has already and Kulbir Singh sir has already told us, this thing, the most common is the oral route, that is contamination of the food going into the intestine, and then the portal circulation and coming to the lung. Then the second, this thing is your skin penetration. Some of the worms are can enter our human body by through the skin. This thing causing some irritation and then entering into the blood circulation and then finally the lung. And then the third one is the vector borne, that is most common, is the mosquito, and especially Wuchereria bancrofti, that is spread to us by the bite of the mosquito. These are the three things which are most commonly the route of transmission of the parasite.
Thank you very much, Dayanand sir. You wonderfully explained all the details about your common parasitic infections in your practice. Yes, I fully agree. The Hydatid is the majority of the time incidental finding. So routinely, we take X-ray, we find that some these well-defined rounded lesions without symptom. Some patients, they have symptomatology like cough and hemoptysis. So varied symptomatology, and the Wuchereria bancrofti can cause some tropical pulmonary eosinophilias and mimics asthma and all. So the mode of transmission also you likely pointed out, the ingestion route and the transdermal route and other inhalation route very rarely. So thank you, Dayanand sir, for this wonderful insight on this common parasitic infection in your practice. I'll move on to Dr. Komal Shah. So, Dr. Kulbir already mentioned in detail about the eosinophilic lung disease caused by the parasite and all. Can you throw some light on what are the eosinophilic lung diseases caused by the parasites and how to approach? Because these kind of eosinophilic lung disease, you do the clinical examination, other thing and all, it almost closely, like kind of asthma, and there is a peripheral eosinophilia, and total IgE level is high. So, how to clinch the diagnosis of eosinophilic lung disease? Whether is it tropical pulmonary eosinophilia or Loeffler syndrome and all. So, what are the eosinophilic lung disease caused by parasites? Over to Komal.
Thank you, sir, for the beautiful question. So, basically, am I audible properly?
Audible, yes.
Yes, yes. So, we can divide it in three groups. When it comes to eosinophilia with parasitic infection, we can divide in three groups. First one is Loeffler syndrome. Second is tropical pulmonary eosinophilia. And third is visceral larva migrans. So Loeffler syndrome is associated with transient pulmonary infiltrates. So patient could be asymptomatic, but there are transient infiltrates along with eosinophilia, or there can be some presentation like bronchospasm and cough. So here it is secondary to the worms. When they are passing through the lungs, there is hypersensitivity reaction which leads to this transient infiltrates. In these cases, again, the eosinophil count will be high, and the infiltrates can resolve by itself in 2 to 4 weeks itself. So this is one diagnosis. Second is TES, or tropical pulmonary eosinophilia, which is secondary to microfilaria. So here the presentation is a little chronic. The patient present with fever, cough, hemoptysis, or weight loss, malaise, and it will be a chronic finding. Plus the patient will be from the endemic area, and he will respond to DEC. That is very important point. And third is transient larva migrants. And in tropical pulmonary eosinophilia, again, eosinophil counts will be very high and IgE levels will also be high. And third one is visceral larva migrants, which is roundworm from dog roundworm or cat roundworm. Here you can find the nodular opacities, which could be calcified also. And again, we have to keep a high index of suspicion when we are seeing eosinophilia with this kind of presentation.
Thanks a lot. A wonderful explanation about the eosinophilia lung disease, low flood syndrome, and tropical pulmonary eosinophilia and larva migrans and all. So thank you. And may move on to the Dr. Kulbir Singh, sir. So Komal clearly explained about the eosinophilic lung disease, the low flood syndrome and all. So low flood syndrome mainly the immunologic allergic reaction. So what is your take or what is your insight into that low flood syndrome, Dr. Kulbir Singh?
Thank you, Dr. Jayaraman, sir, for giving me opportunity. Loeffler syndrome was first described in 1932 by William Loeffler, in which he described that there are some respiratory symptoms like asthma and peripheral eosinophilia is there, and there are transient pulmonary infiltrates in the lungs. It is a first type of hypersensitivity response in which basically cough, dyspnea, chest pain, hemoptysis, and this chest pain, they all can occur. It is Loeffler syndrome occurs usually after 1 to 3 weeks of the infection caused by the larval migration from pulmonary circulation to the pleural, alveoli. So during this phase, there are transient pulmonary infiltrates and peripheral eosinophilia is also seen. This pathophysiology is shown by the damage to the respiratory epithelium, because which there is increased mucus secretion. So it is usually caused by Ascaris lumbricoides and ankylostoma duodenale, strongylitis, and also rarely it may be caused by Aspergillus fumigatus and some drugs like non-steroidal NSAIDs. It can be caused by them also. Ascaris larva can be seen in the sputum or the gastric aspirate in such during this phase when the larva is passing through the lung. So it can be seen in the saliva or gastric aspirate. But the stool examination, when we will do stool examination during this phase, Loeffler's phenomena, we will not find any ova parasite. Ova examination is negative during this phase of Loeffler syndrome because the ovas are past 8 weeks past the infection. So it is in the late phase you will detect ova in the stool. So during this phase of the pulmonary migration, peripheral eosinophilia is seen, and larva may be seen in the sputum in such phase. So Loeffler syndrome may be managed by symptomatically. They can be managed by the bronchodilators. If the asthma is there, steroids, but anti-helminthic drug will not act much during this phase. So basically, it is a type 1 hypersensitivity response, and now we know better regarding this phenomena. Thanks.
Thank you very much, Dr. Kulbir Singh's wonderful explanation about the Loeffler syndrome. It's a hypersensitivity reaction. This is an allergic reaction to this parasite causing the wheezing, cough, sometimes hemoptysis, and nodular infiltrates and transient pulmonary eosinophilia, etc. There is a eosinophil count is high. So treatment is well response with these bronchodilator and other medications. So how long are you going to give this treatment, sir? Loeffler syndrome? Any duration of treatment for Loeffler syndrome? Kulbir, sir?
Duration of treatment, it is symptomatic treatment, and it can be given for sometimes for quite a long time, a week or 2 weeks. So it may not respond. The response is not just a quick response to the drugs, because the helminthic drugs don't act during this phase. So you are dependent on this all bronchodilators and steroids and these things. So anti-helminthic drug don't act during this phase. That's why the response is sometimes poor also. So you have to go through them.
Thank you, sir. So I'll move on to Dr. Bhushan, thoracic surgeon from Apollo Hospital, Indraprastha Apollo Hospital from Delhi. Already, Bhushan, you explained clearly about the indications of surgeries and which disease requires the surgical excision and all. So once again, can you throw some light on role of surgery in parasitic lung infection? How do you prepare your patient pre-operatively?
Yeah. Can you hear me?
Yes.
Yes. So when you are considering parasitic lung infection, especially surgeons domain come in case of a Hydatid cyst only, which is the most commonest in India and eastern part of India. So these cases, first of all, you should, once the clinical diagnosis is made, a fiber optic bronchoscopy has to be done to see that any pre-existing infection is there or not. So a lot of times you can see the membrane seen within the bronchoscopy. Second thing is basic lab. The routine labs, especially the liver function tests, are very important because these patients you are going to start on imidazole group of drugs like albendazole, mebendazole, and then the cardiopulmonary fitness like PFT and DLC if you're planning for any lung resection procedure, and 2D echocardiography for cardiac assessment. These all things are the basic requirement for a preoperative assessment, and this patient should be started on albendazole minimum 11 days to 2 weeks prior to surgery.
Thank you. Thank you very much for this wonderful explanation about the role of surgery and the medical management. Dr. Komal, I have one small question about the medical management in Hydatid cyst. The drug of choice is albendazole. Is it
Yes.
mebendazole? It will work or it won't work? Mebendazole.
So
What's
it is
the
an
reason?
alternative.
Yeah.
It is an alternative. So basically, we don't give in pulmonary hydatid cyst. We don't give it before the surgery because it will thin down the layer and it can cause hypersensitivity reactions, anaphylaxis at the time of surgery. So we can give it after the surgery if the remnant of cysts are there, and it should be given for 28 days followed by 14 days of interval again for 28 days if cysts are still present.
Now I'll move on to Dr. Dayanand, sir. Sir, already our panelists explained about the eosinophilic lung disease in that tropical eosinophilia syndrome, TES. So what is tropical eosinophilia? What is the clinical presentation? How to diagnose and how long we have to give the treatment for TES, that is tropical pulmonary eosinophilia? Dayanand, sir?
Right, sir. Thank you, sir. Actually, this tropical pulmonary eosinophilia is a hypersensitivity reaction to the worm Wuchereria bancrofti larvae. Actually, it has got 5 forms in its life cycle. We are infected by the mosquito with the 3rd one. Then 2 cycles occur and the change of adult worm. Then the first adult worm, when it gives the larva, that is known as microfilaria larva. And it has got a very peculiar thing that it releases in the middle of the night when the mosquitoes tend to bite us more. It's a nature's gift. And this was first described by tropical pulmonary eosinophilia or TES, that is tropical eosinophilic syndrome. It was described first by Wingarten back in 1943, I believe. And they used to call it as pseudo-tuberculosis with eosinophilia. That is one point, because I believe there are many PGs listening to this. These are minute points which are very educative. So I just wanted to highlight this. And it is diagnosed by a clinical criteria. Like there was a study done by Kune et al. And who presented their paper way back in 1999 in a respiratory journal, where they said that the place where the person is living, that is very important, that the incidence of the disease should be there. That is first criteria. Second is nocturnal cough symptomatology or getting breathlessness during the night. And the third was eosinophilia. And the 4th main important was response to DEC, that is diethyl carbamazine. So diethyl carbamazine is given 100 mg 3 times daily for almost 3 weeks. And there is a good relapse rate also. Because some people tend to be like totally cured, but some people tend to come back. So this thing, and coming to the symptom, diagnostic workup, the specificity, sensitivity of certain tests, like filarial antibody test was almost 30%. And then if you see the radiological changes, it was almost 45% in the study. And then ESR was most 80%. And then Vijayan sir's research with his team, he has published actually IgM, IgG, and IgE antibodies also for against filarial antibodies. These are the tests which I came across while preparing for this.
Thank you very much, sir. So tropical eosinophilic syndrome, previously called it as the pseudotuberculosis. Yes, been gotten named previously, and there are a lot of testing facilities are available. So DEC is treatment of choice. We have to give 3 weeks minimum. So wonderfully explained about the tropical eosinophilic syndrome, sir. So thank you very much. May I request Dr. Kulbir Singh, sir, can you throw some light on visceral larva migrans? What is it and how to diagnose this visceral larva migrans?
Visceral larva migrans is an infection caused by the Toxocara canis. It is a parasitic roundworm. It is usually found in young children, and the young children living in the poor areas where there is a high load of the this eggs. So in crowded dwelling, there is an ingestion of the embryonated eggs by the children. They go through their intestine where they release larvae from intestine wall. They move to blood vessel. Through blood, they move to liver. Then they can move to brain also, and heart and liver and lungs. So what happens that during the migration through the organs, some of the larvae they become dormant. They can again start their revive and again moving to different organs. Ultimately, they calcified in the organs. So during this phase, there are a lot of symptoms like anorexia, weight loss, cough, and the patient is usually the findings are that the blood findings are hypereosinophilia and is there whenever there is a migration of this larva. So unlike strongyloides, the hyperinfection, the sputum of such patients, the patients suffering from Western larva migrans, they don't contain any larva. You will not find any larva. So in the chest X-ray, you will find bilateral, patchy, sometimes unilateral infiltrates are there. So ultimately, the pathology is the diagnosis is by positive. Now, about the diagnosis of visceral larva migrants, this positive serology in the child or by the biopsy of the muscle. Sometimes the larvae are calcified in the muscle tissue, so you can find them in the muscle biopsy. So larvae are typically 400, 500 by 18 to 21 millimicron, and they are minute single lateral LI. They are having minute single lateral LI. The necrosis of tissue secondary to the larva migration can cause eosinophilic granuloma also, which can be seen in the slides. There is a increased IgE. IgE is increased in such patients, and the parasitic usually treatment is albendazole, mebendazole. We give for visceral larva migrans. So basically, seen in children below 5 years. This visceral larva migrans. Sometimes blindness can also be caused when the larva migrates to the eye, which can cause blindness. Or leukocoria, white pupil is seen, which is because of the migration to the eye, which can further cause to blindness. So visceral larva migrans is basically the passage through the various organs. The larva multiplies and sometimes become dormant, then again revives. So this phenomena continues. So it is a chronic phenomena, becomes chronic phenomena ultimately.
Thank you very much, sir. Kulbir, you were wonderfully explained about the visceral larva migrans, occurrence commonly in children, and the mode of presentation, diagnosis, treatment modalities. Thank you, sir. We'll move on to Dr. Koshal. What will enter into the disease called schistosomiasis, caused by the Schistosoma japonicum and Mansoni. So, what is Katayama fever or acute schistosomiasis?
Thank you for the question, sir. So, Katayama fever is acute toxemic schistosomiasis. So, when a non-immune traveler goes to the endemic area, then there are the symptoms like if it gets infected, then there are symptoms like fever, malaise, rash, abdominal pain, and it is again due to the migration of larvae through the lung passages. So, when we do radiological X-rays and CT scans, will show us nodules, ground glass opacities, Then there can be presentation as mass also, and we can diagnose it with the presence of eggs or larva in the sputum. In bile culture, we can find that, or even in stool or urine. And the more sensitive test is also PCR. The treatment will be here. Initially, we have to give steroids, high dose steroids for 48 hours till the symptoms are settled. And after that, we have to give praziquantel, which should be given for 3 days. And then we have to again give it after 14 days for the adult larva, which will be formed later. And then again, we have to repeat it after 3 to 6 weeks.
Okay, fine. So this is acute schistosomiasis or ectodermal fever. The treatment choice is prosequental, and acute phase we have to give steroids. Okay, fine. Thanks. Yes. So what is the link between the chronic schistosomiasis and the pulmonary hypertension? Chronic schistosomiasis and pulmonary hypertension. Can you throw some light on this chronic schistosomiasis causing pulmonary hypertension and carpulmonary? Komal, can you? Yeah, just unmute your mic.
Yes.
Yeah, right. Thanks.
Yeah.
Chronic.
Yes. Yes, so chronic schistosomiasis can present as pulmonary hypertension. Maybe in 5% of chronically infected patients of schistosomiasis can present as pulmonary hypertension. And in endemic area, almost 30% patients of pulmonary hypertension are due to schistosomiasis. Those who are present in endemic area. The mechanism behind this could be obstruction of the pulmonary vasculature by the larva, or it could be egg embolization, or it could be secondary to inflammatory vasculopathy. Generally, Schistosomia mansoni is more common of doing pulmonary hypertension than Schistosomia japonica. Treatment here is again the same. Phosphodiesterase 5 inhibitors or endothelin receptor antagonists or prostacyclins.
Thank you very much. This is one of the secondary cause of pulmonary hypertension. Schistosomiasis can cause in chronic conditions. The mechanism behind is the embolization of the schistosomes eggs in the pulmonary vasculature, as well as the pulmonary vasculopathy, involved the vascular areas which causes the pulmonary hypertension. The treatment, along with the prosequental, we have to give some pulmonary hypertension, anti-pulmonary hypertension medications like sildenafil, bosentan, and treprostinil and all. So this is the treatment for the chronic schistosomiasis. So thank you, Kamal, for nicely discuss about the schistosomiasis, both the acute schistosomiasis and chronic schistosomiasis. So thank you very much. May I request Dr. Kulbir, sir? Kulbir, sir, the lung fluke.
Sir, I think sir wanted to say something.
Yeah, please.
Dayanand, sir, wanted to say something.
Yeah, please, sir.
She pointed out that Mansoni causes more hypertension than the Japonicum. So can the reason why? It is because of the egg laying layers, like more complicated in the Mansoni than it is very simple in Japonicum. That is what I just wanted to.
Thank you. Thank you very much for the update, sir. Nice, sir. Thank you. Dr. Kulbir, sir, lung fluke or Paragonimus westermanni, we call it as lung fluke. So can you throw some light on paragonimiasis associated pleural effusion and how to evaluate? The pleural effusion, there are a lot of parasites can cause pleural effusion. So Paragonimus westermanni causes pleural effusion. How to approach? So what are the parameters look in, and what's the treatment modalities for the paragonimiasis or lung fluke, sir?
The lung flukes basically they may be confused with pulmonary tuberculosis in many cases. Usually seen in eastern part of India, Manipur, we see many cases of them. What happens? The Paragonimus westermanni, they enter the human host via when the person eat the freshwater crab, a crustacean. When they eat, the encysted metacercaria with crab enters in the human body, where they release various larvae into the small intestine. From small intestine, they enter to the peritoneal cavity. From there, what happens? They enter to the diaphragm, and when they enter to pleura, due to pleural reaction, pleural effusion happens. The pleural effusion of lung flukes, it is quite different from the effusion caused by the pulmonary tuberculosis. the effusion of lung flukes, it is mostly lymphocytes are less than 50%. Whereas what we see in pulmonary tuberculosis, the pleural effusion is more than, lymphocytes are more than 90%. So it is in lung fluke, lymphocytes are less than 50%. Other is eosinophilic. In the lung flukes, the effusion is eosinophils having more than 10%. They can go up to 30-40%, whereas it doesn't happen in the pulmonary tuberculosis. Other is LDH. LDH is more than 1000 IU per liter in cases of lung flukes. And other is subpleural linear opacities. Subpleural linear opacities are seen in the lung flukes when the pleural effusion in the lungs, whereas doesn't happen in the case of pulmonary effusion. And other is the residual pleural fibrosis is not seen in cases of lung flukes pleural effusion, whereas in the post-pulmonary tuberculosis, pleural effusion, we see sometimes pleural fibrosis occurs. So this is the difference between the various the tubercular pleural effusion and the paracombination lung fluke pleural effusion.
Thank you, sir. Thank you, Kulbir, sir. So, in the pleural fluid, we have to see the eosinophil count. High eosinophil count in pleural fluid, one of the suspicious for the parasitic infections caused by the paragonimiasis. Komal ma'am, any other test to confirm the paragonimiasis in bronchial was or histopathology or stool or anything? Any other diagnostic tool to confirm paragonimiasis? Usually in serology, sometimes serology help in identifying the paragonimiasis infections and all, apart from the eosinophilic count, raised eosinophil count in the pleural fluid. So, okay, fine. Thank you, sir. Thank you, Kulbir, sir. So next we move on to the Dr. Dayanand, sir. The pulmonary amoebiasis. This is the commonest infection we come across in our country. What are the mode of presentation in your practice? Like how these amoebiasis present with in our practice, and what's the diagnostic tool and how to manage this pulmonary amoebiasis? Dayanand, sir.
Actually, pulmonary amoebiasis has been highlighted by Komal in her presentation is by Entamoeba histolytica. The cysts, which are infective form, enter our body into the gastrointestinal system. They are resistant to acid in the stomach. They reach the colon and they exist to form trophozoites. The trophozoites can affect the intestine and cause the intestinal symptoms, and then they may enter the bloodstream through the venous into the portal circulation. And the most common site for extra intestinal amoebiasis is the liver. The right lobe of the liver has been described most, and it can occur on the left also. When the right lobe of the liver is involved, and if it is subdiaphragmatic, there is a chances of subphrenic abscess or this thing irritating to the lung and direct spread to the lung also. That is one thing. And the second thing is reactionary effusion occurring, then the inflammation, then all the necrosis and all. Then sometimes there may be a frank fistula between the bronchus and the abscess, expectorating the so-called anchovy sauce. I don't know what that anchovy is. Recently, somebody told me that it is a kind of fish. After 20 years of searching, anchovy is a fish, I believe. And the sauce of it, there are some people who are vegetarian like me, don't like to be called so, called it chocolate sauce. So that is the typical described. Sometimes patients who have the fistulous communication can expectorate that kind of this thing. Typically liver abscess, when you drain, the description is given like that, chocolate or anchovy paste, like this thing. And the treatment, of course, is your metronidazole, or the alternative is tinidazole. And it has to be given IV for almost 1 week to 10 days.
Thank you, sir. Thank you very much for this wonderful insight on the pulmonary amoebiasis. We had a patient recently, 3 weeks back, one patient presented with a For 45-year-old male patient is a bank employee working in bank employee. He is staying in a large hotel room and used to have food in the hotel always 3 times. He came to us in the general medicine department with passing loose stools on and off for the past 2 months duration. And again, the patient developed little fever and mild right lower side chest pain. And the general physician took the X-ray, shows some kind of haziness in the right lower zone, obliterating claustrophrenic cardiophrenic angle. They suspect some pleural effusion kind of thing. So immediately referred to us in the form of right chest pain with a pleural effusion, referred to me for the further evaluation. So we did an ultrasound, any fluid is there and all. So accidentally, we picked up the lesion found in the liver also. Liver, there is a small kind of amoebic, there is abscess, a liver abscess, we don't know what kind of thing, and the irritating the diaphragm, causing the reactive pleural effusion. But the time patient presented with a fever also, fever, slight toxic look. So the pleural fluid is somewhat internal echoes, suspicious of some kind of empyema and impending rupture. They said the impending rupture of the amoebic the liver abscess into the into the pleural cavity and all. This was the diagnosis, and patient had around 1,000 ml of pleural collections. This is the patient admitted in our department. We did a pleural aspiration and image guidance. There is some turbid fluid with some different kind of thing. There is a anchovy sauce or chocolate color sauce, different kind of thing. We named it. We have aspirated and sent for the testing. And which shows, because patient is toxic, we look like pyothorax. So immediately we put the intercostal drainage and drain entire effusion. The report came yesterday as the amoebic liver abscess. For that, we started the metronidazole for 10 days in the hospital. But ICD was removed after the 1 week time. Patient almost is normal, except the ICD drainage. Patient underwent ICD drainage for the first amoebic, that is in the pleural cavity. This is a complicated liver abscess, eruption into the pleural cavity. But with the medical management, the liver part is slowly strengthened. After the 4 weeks, we took the ultrasonogram and tested everything. There was no liver abscess. The pleural cavity was completely normal. So this is the one case recently we come across in our center. This is a pulmonary amoebic liver abscess rupture into the pleural cavity, causing empyema and the patient toxicity, etc. So this patient managed well with metronidazole 3 weeks, apart from the intercostal drainage in the acute phase. So thank you, Dayanand sir, for the wonderful insight on the amoebiasis. May I move on to Dr. Komal ma'am. Komal, already Dr. Bhushan clearly explained about the hydatid cyst management. The treatment of choice is the any cyst presenting and symptoms or without symptoms also. The treatment of choice is excision or enucleation with or without the lobe. So what are the medical management available for the pulmonary hydatid disease? How to diagnose the pulmonary hydatid disease? What is your experience in the presentation wise? Asymptomatically present or the incidental finding of hydatid disease, or patient present with some symptomatology, and how do you approach this pulmonary hydatid disease?
Yes. So, sir, here also I will also like to share one case. So the patient is an elderly female who presented to us last month, and she had history of cardiac hydatid cyst, pericardial hydatid cyst, for which she was operated, and in histopath they were confident that it is hydatid cyst. And now she presented with lung lesion, and it was a proper nodular lesion, and we had this suspicion of again hydatid cyst. IgG was also positive this time, but we did BAL, and her galactomannan came positive, and even aspergillus PCR came positive. So she was this time not having hydatid disease, but aspergillosis. However, I just like to put this case here because it was an interesting case where we were suspecting pulmonary hydatid in her, and it turned out to be aspergillus.
Thank you.
So, anyways, coming back to the question. So, patient may present asymptomatically, and with just with the radiological findings like crescent sign or meniscus sign, there could be air fluid level if there is some rupture, or daughter sign. There could be signs of radiological findings. However, the immunological findings are signs are like they are not very specific. They are they have low specificity, so we have to go clinically plus radiologically plus immunological finding. And as sir mentioned earlier, surgery is the treatment of choice. we should not be giving albendazole before surgery, and if after surgery we have to give for 28 days followed by 14 days of interval again after 28 days. So see 3 cycles like that.
Thank you very much for this wonderful insight about the treatment modalities. So treatment is we have to give albendazole for the 28 days and give a break and again start the treatment. This is 4 to 6 cycles you have to complete, na?
Yes, sir.
Fine. Okay. Thank you, Komal, for this wonderful explanation about the Hydatid disease diagnosis and management. And we'll move on to Dr. Bhushan, sir. Bhushan, sir, you explained clearly about the Hydatid disease diagnosis, management, and all. Again, one more thing here. So, in the case of Hydatid disease, you told surgery is a treatment of choice. Suppose the patient is severe cardiac failure, not able to undergo the surgery, but cyst is there causing symptoms, some obstructive symptoms. So, how will you approach these cases without surgery? So, do you have any interventional procedures? May I ask the questions to Komal also? So, do you intervene without any surgery or with the help of, because surgery is not a, surgery is contraindicated because of the severe cardiac failure and all. Patient is not able to undergo withstand the surgery by general anesthesia and other thing and all. So, in that case, there is a cyst is there with the compressing symptoms. And how to evaluate these kind of cases? Any interventional procedures is there to, without rupture, how to remove the cyst or collapse the cyst?
Yes. So in India, we get all kinds of patients. Some patients don't come up for follow-up. You start albendazole, they keep on taking albendazole, and some cysts disappear also. So as I had shown in the second case, where the left lung cyst had disappeared and the liver had become more mature. So that may be sometimes the fate. Sometimes the small cyst may get disappeared, but if it is large, like more than 5 centimeters, it may may sometimes get ruptured. Once you give albendazole, it thins out the cortex of the cyst, and it might get ruptured and may get complicated. In those cases, once it is thinned out, you can do percutaneous aspiration, needle aspiration, and installation of, if at all required, any scolicidal agent. But I have never seen this procedure being done that commonly. Any insights, Dr. Komal?
Same experience, sir. I have not seen much of this pair surgeries being done. And medical management, we are not sure whether it can reoccur again with the medical management.
So prolonged treatment is required, especially if you are suspecting Hydatid, Echinococcus multilocularis, which behave like a malignant disease.
Yeah. So here we will get more loculated cyst and more of calcified. Yes.
Yeah. Thank you. So our chairman, Dr. Sir, has sent a message. There is so far 1,393 logins now. As of now, around 1,400 people are logging in this webinar. So thank you all for this wonderful star panelist and explanation about beautifully all about the parasitic infections. Thank you, Krishna sir, and thank you all the panelists and all. Thank you very much. So we'll move on to the pulmonary manifestations of malaria and diagnosis and treatment. Komal, you said malaria is very common in our country. In Chennai also, previously we called it as an endemic city. Chennai is an endemic city. Nowadays, we see very hardly MPQB, maternal fever, chills. Very rare malaria nowadays. So, what is in your place about the malaria? The common presentation is the telemedicine people they look in. For pulmonary manifestations, I have seen one case in last year, I believe. Patient presented with non-cardiogenic pulmonary edema, ARDS, and we did all the investigation. That shows the MPQBC positive and everything. We started on primaquine and other drugs. Patients resolved all the opacities and went home happily. So this kind of thing. So what is the common? Is it a very common thing in the pulmonary manifestations of malaria, and how to approach this case of malaria?
Yes, sir. Yes, sir. We do see pulmonary ARDS in cases of malaria. It is not rare. And it is not very common, but we do see this kind of patients. However, the incidence of malaria itself has gone down. So that's why we are seeing less ARDS patients now, because overall this year we are not seeing much of malaria patient itself. That's why. But we do see patients with malaria, with pulmonary edema and ARDS. And treatment again is with artesunate or artemether as per the guidelines. If it is not available, then only we'll go for quinine therapy. but it is available, widely available, and they respond well to this kind of treatment. And again, the diagnosis, as you mentioned, sir, it is very simple: thick smear, thin smear. Even now, rapid tests are available. We can do PCR for the malaria, and this X-rays and CTs will show as pictures of ARDS.
Thank you, Komal. This is because malaria previously very common. Nowadays, we are seeing less number of cases. This is the commonest presentation we come across. ARDS, cardiogenic non-cardiogenic pulmonary edema, sometimes consolidation. Yes. So nice. Sir, thank you. Dr. Kulbir, sir, can you explain about the toxocariasis, diagnosis and management of the toxocariasis?
Diagnosis of toxocariasis can be done by ELISA TES. TES is toxocara excretory secretory antigen. So this can be done, and which can be further confirmed by Western blot, followed by Western blot. Other is total IgE is raised in this toxocariasis, usually 850 KIU per liter, and 79% of cases. ESR is raised, and other is we can do CT scan, especially if we do CT scan of the liver. If the involvement is in liver, we see the hypoechoic lesions during sonography. In the sonography of liver shows hypoechoic lesions when the involvement is in liver, especially when the involvement is in the toxocariasis in the lung. We see usually pulmonary nodules surrounding by ground glass opacities. So multiple pulmonary nodules is seen with surrounding ground glass opacity. So in cases of eye, when we do the fundoscopy in toxocariasis, we can see the retinal detachment, chorioretinitis can be seen, and leukochoria can be seen. So it depends on the site where it is involved and how to diagnose that site. So other is one can do the antibodies when the antibodies are against TES AG antibodies are raised against, then it shows then there is acute infection of toxocariasis. When the antibodies are formed against the toxocara excretory secretory antigens, then when we measure the titer of such antibodies, when they are raised, then that means that the acute phase of toxocariasis is going on. So in this way, we can diagnose toxocariasis, whereas the management is concerned, albendazole 400 milligram BD for 5 days can be given, or mebendazole BD 100 milligram mebendazole BD for 3 days can be given in such cases, as per the management is concerned. So overall, it is a chronic disease, and maybe we have to repeat the dose again. Such cases of toxocariasis.
Thank you very much, sir. You said very clearly about the diagnosis and management of the toxocariasis. It's a chronic form of parasitic infections, toxocariasis. So we need to have a long-term treatment and a follow-up to prevent other morbidity, mortality. Thank you, sir. So we'll move on to the chat box question. Our Dr. Tridip Chatterjee from Mumbai, Maharashtra, sir has put up one message. HRCT image in tropical pulmonary eosinophilia has many times random nodules with eosinophilia, confusing with the miliary. But important differentiating feature is in TPE, that is tropical pulmonary eosinophilia, these nodules are commonly surrounded by areas of GGOs which differentiate. Yes, I fully agree with sir. There is an area of GGOs. So any take point on this, sir? The Dayanand, sir, GGOs surrounding the nodules.
Yeah, GGOs around nodules.
Yeah, how to differentiate the biliary nodule and
mottling. Miliary mottling has been the common distinguishing like DDs, which we discuss in case of tropical pulmonary eosinophilia.
Yes.
So of late, I have not seen any HRCT chest with this kind of a picture.
Yes, sir. Thank you, sir. And one more question again, Dr. Tridip Chatterjee, sir, is asking. Not is just updating the thing. Pulmonary hypertension due to cystosoma is a group 1 pulmonary hypertension. Yes, I fully agree with you, sir. Thank you, sir. And Dr. Tridip Chatterjee again asking one question. How common is toxoplasmosis in a immunocompetent patient? Dr. Komal, can you answer this question? How common is a toxoplasmosis in a immunocompetent patient? Or Dayanand, sir?
I think Dayanand sir can answer it better because we have not seen much of toxoplasmosis in an immunocompetent patient. No, I have seen only in immunocompromised HIV patients with low CD4 counts.
Okay. Dayanand, Kulbir sir, I also very less experience about this toxoplasmosis and all. Anyway, so may I ask one more question? Subject to Dr. Dayanand sir. So what is diarrhea-filariasis? So what is it? How to diagnose this diarrhea-filariasis and management, sir? Dayanand sir.
Diarrhea immitis is a dog heartworm, which is more seen in USA and all. Actually, it is the worm, that is filaria worm, that affects the dog, the man's most faithful friend. It is transmitted by mosquito bite, and the larva of it travels to the heart of the dog, and there it multiplies and the generation goes on. Human being affected by this worm is by mistake, or rather because of the company. And the worm doesn't develop further in our human beings. It is just arrested by our immune system. It can't develop further. So in the lungs, because it is a vascular liking a vasculature, it travels and it is arrested in the blood vessels of the lungs, forming a nodule type, which may mimic sometimes as a solitary pulmonary nodule, for which when we evaluate, we by chance get to know about it. So there is no diagnostic test, and in this, the eosinophilia is absent. And secondly, the excision is the diagnostic and curative.
Oh, excision of the nodule, SPN. Nodule. Present as a solitary pulmonary nodule or small mass lesion, we have to excise it.
Yes.
There is no specific treatment for this also.
That's all.
Okay. Thank you. Thank you very much, sir. May I ask Dr. Bhushan, sir? So, any role of decortication in empyema caused by amoebiasis or paragonimiasis or any other parasitic infection causes the complicated effusions like multilocular empyema and all? Role of decortication.
Yes, in hydatid cyst we have done this thing, a ruptured hydatid cyst complicating with empyemas because there is a bronchus communication and they have a hydropneumothorax and eventually getting converted to empyema. These patients we have operated with proper VATs and or open decortications, and retrospectively we found out that it was a hydatid cyst. Yeah, these things have happened. And in literature, if you see, there are case reports with some decortications done and Paragonismus westermani as the causative agent being found. Amoebic liver abscess rupturing into the pleural cavity. Obviously, the treatment is metronidazole, and draining the pleural cavity by chest drain. Most of the times, chest drain itself helps it. If at all there is a liver to pleura connection, maximum you can do a thoracoscopy, clean the cavity. And one case I had put the chest drain via the diaphragm into the liver abscess cavity, because that liver abscess cavity was well adhered to the diaphragm, so that opening the abdomen and draining it was a different, you will be contaminating the whole abdomen cavity. So we had done a phrenotomy, taken a purse string suture and put the chest drain into that and gradually withdrawn it over 3-4 months. The patient was very nice later on. So these are a few 2-3 experiences we had during our last journey of 10 years treating all these infectious lung diseases.
So do you perform all the surgical interventions through the video-assisted thoracoscopic surgery or open method?
Yeah, nowadays majority of the procedures are VATs or robotic. But if it is a ruptured hydatid cyst, and when we find that the cyst is bigger size and there are probabilities that it will rupture and contaminate the field, then definitely we plan for open surgery. And we can just open a small muscle sparing thoracotomy. The results are as same as VATs and the pain is also less.
Thank you. Thank you. Wonderful explanation about the role of surgery, decortication, and the diaphragmatic repair using the uniportal video-assisted thoracoscopic surgery. Thank you very much. Komal and Dayanand sir, is there any national program for this parasitic infection control program? Like previously we have a malaria eradication program, deworming program, and all. So there is a February 10th. There is a national day. There is a national deworming day in our Indian government is doing, and we evaluate all the school children. They used to give a single dose of albendazole up to 19 years. This is mainly for the ankylostoma duodenale. That is hookworm infestation causing anemia and abdominal colic and diarrhea. No? This is the one indication, or is there any other indications for this albendazole? As a government, what's the government policy in that? National eradication program for malaria as well as the hookworm infestation.
You have caught me on the wrong foot.
Whichever maybe you said, no problem. Just discussion.
Actually, whatever I have prepared are the books borrowed from my daughter, and she's yet into the SPM.
Oh,
so not yet gone through the SPM. This thing.
Correct.
But anyway, I do a general practice also. So where in the evening, these anxious parents come and ask me, sir, these tablets have been given to my child to be taken. Should I take it or not? Initially, I didn't know what the tablet was. I thought it was some multivitamin or something. Then when I found out from the local people that it was just albendazole. Then later on, my compounder himself is telling now don't ask doctor, you take it, no problem. That is
here now. Yeah. Nowadays, we are seeing less number of cases of malaria and all. Is there any active program, malaria eradication program? I don't think so. Is there regularly? They are doing all the program for malaria eradication.
Yeah,
fogging and everything is done. Preventive measures are being taken. That is the main part of the eradication program. Otherwise, the incidence rate has gone down itself.
Yeah. Thank you. Now we'll show some interesting cases. We'll discuss briefly about that. I will share my screen. My screen is visible, Komal ma'am?
Yes, sir.
I'll go through the presentation. Yeah. This is the case. Already similar case Dr. Bhushan presented. This is last year I had this case in our hospital. 22-year-old male from West Bengal, presented with chest discomfort, breathlessness, cough for 6 months, no hemoptysis, no fever. Respiratory system revealed a dull note and diminished breath sounds in the left infrascapular region. So this is the chest radiography. Kulbir Singh sir or Komal, can you comment on this chest radiography? It's almost similar to Dr. Bhushan's case. Komal, you can see there are 3 large homogeneous opacities in the right hilar and the right diaphragmatic, the right lower zone, and there is a lesion, well-defined lesion with some air in that. This is a air crescent sign, very classical presentation.
Classic. I'll
move the next slide. You can see very clearly. So this is the lesion present in the this is a mediastinal window. You can see there are 3 cystic lesions, uniformly rounded, well-defined lesion present in the right side 2 cysts and left side 1 cyst. Again, this is a liver cut. You can see here there is again 3 cysts in the liver also. So this is a hepatic and hydatid cyst. The treatment of choice is excision, enucleation of the cyst. This is a Barrett's procedure or Barrett's procedures with the capital H. Already Dr. Bhushan showed clearly. So this is the it's not going in. I don't. Okay, I'll move on to the next slide. Yeah. Here, see, this is without rupture of the cyst, we can take it out. So this is a large hydatid cyst from the left lower lobe. So we didn't remove any lobe at all here. This is the less than 50% occupancy. So complete enucleation of the cyst is fine for this patient. And this is, you can see a lot of membranes and the daughter cyst and a lot of thing and all here. This is hydatid cyst. Already we discussed in detail. A lot of signs, water lily sign, camelot sign. This is the water lily. This is the water lily sign. You can see very clearly. Meniscus sign or detachment sign. So double arch sign. This is various separation of the endocyst from pericyst causes the entrance of air. This is the meniscus sign. And this is the meniscus sign. You can see. We'll move to the other case. This is a 34-year-old female patient from Manipur. Occupation is a fisherman. So past C, non-significant. Presenting complaints, chronic cough and hemoptysis. There is a mild blood sputum on and off with a chest pain. Physical examination shows a respiratory distress. Patient is present to the emergency with the respiratory distress and decreased breath sounds over the right lower lung field. And this is the imaging chest radiograph as well as the CT scan. CT shows there is patchy infiltrates and cavitations in the left lower lobe. And the laboratory investigation shows eosinophilia. Imaging study CT scan, you can see clearly multiple nodules with there is a dense consolidation of small cavitation here. And we did the sputum examination, gram stain, AFB, expert MT, everything is negative, non-diagnostic. So what is this? This is a special stain for this one particular parasite. Anyone can attempt. This is a perpendicular stain sputum specimen from a patient. This is a special stain. Okay, this is the answer for this. This is a Paragonymous westermanni. Treatment already mentioned, the prosequential, and how does the infection occurs? Ingestion of raw or undercooked freshwater crustaceans is the culprit behind. And the clinching diagnostic is the good history is very, very important, including a diet history and place of residence. So this is a Paragonymous westermanni, lung fluke. You can see here clearly. So this is the other case. This is a 42-year-old male, is a bank employee. Pausis is non-significant. Presenting complaints are chronic cough, wheezing, and fatigue. There is on examination patient present with the respiratory distress, wheezing on auscultation. So this is the lesion X-ray chest radiography shows diffuse pulmonary infiltrates, laboratory diagnosis, peripheral eosinophilia, and elevated serum Ig level. Imaging study shows clearly CT scan of the chest showing migratory pulmonary infiltrates and nodules. Any comment? So, yeah, we asked the pet history. Dog lover has 3 pets.
Dog.
Yeah, passion for gardening. So, what is the diagnosis?
Dog roundworm, maybe visceral larva migrants.
Yeah, yes. Correct. This is a visceral larva migrants. The Toxophora canis is the culprit behind. The treatment of choice is albendazole.
Albendazole, yes.
Is the dog lover,
dog lover.
History and medicinal activities to be included in the history taking. So history taking is very important. In the history, you must ask where is the patient coming from, what kind of job he is doing, whether he's using a chapel in the field workers and agriculture field and all. So a lot of questions and the eating habits, whether cooked food or undercooked food or the uncooked food and all. This is the food history is very important. The patient is taking food in the hotel or home food. So all things are very important. Meticulous history examinations, so we can clinch a diagnosis. So with this, we'll stop. I didn't know the case. Yeah, this is the one. Okay. With that, I stop the screen. Now, we come to the final thing. I request all the panelists, you can give some 1 or 2 minutes take-home messages about this respiratory parasitic infections and how to prevent and what's the diagnostic modalities and tips to the audience. There are a lot of the 1,400 audience here. So I want every panelist to give the take-home messages and tips to the audience. First, we start with Kulbir sir.
Take-home message is that there is a very important role of hygiene for to be observed by the patient, especially children. They should wash their hands before eating food, and they should one should not go barefooted on the sound in the where the dogs and the animals crowded areas there where there is a fecal matter. One should always wear slippers. The barefoot they should avoid it. Personal hygiene is basic thing is patient should cut their nails. Also, they can get the embryonated eggs stuck in their nails while eating. So basic hygiene, good environment, good sanitary conditions, it's must. And people living near water bodies, they should be told, especially villagers and in the urban areas where there are water bodies, they should be told to how to especially take care while handling the freshwater crabs they are eating, the coastal area population regarding the freshwater crustacean, they can get the parasitic infection from there also. Especially regarding the pet, I want to also stress that we keep pets in our houses, and we should be very careful when we keep pet in our house, especially dogs. And also in the colonies, we see there are too many dogs, and especially nowadays the Nagar Nigam, they don't come, municipal bodies don't come to catch the dogs. So their population is increasing. So apart from rabies, the other this parasitic helminthic infection rate is also increasing. So this is my take-home message, that we should observe all the points which I have mentioned, so that
Thank you,
we
Kulbir
should
sir, for
prevent
the
helminthic disease.
thank you, thank you, Kulbir sir, for the wonderful take-home messages from your side. So prevention is better than cure, and hygiene, all the food hygiene, all important thing. So thank you very much, Kulbir sir. So Komal Shah ma'am, from your take-home message for the audience.
Take home message will be that we should keep our eyes and brain open for the possibility of parasitic infection as a pulmonologist, because it can present in various ways, and we generally tend to forget about this parasitic infection. We take all the other differential diagnosis, but we don't look into it. So we should keep a high index of suspicion whenever the topics are there, like the patient is from our age, and we should keep the high index of suspicion, and it can present as various ways.
Thank you, Komal, for this wonderful take-home messages. So high index of suspicious. Any patients, we have to keep some differential diagnosis. Parasitic infections is one of the DD. So don't undertreat or
don't neglect that. Yes.
Don't neglect. It's very important. Thank you very much, sir. May I request Dr. Bhushan, sir, you will take your messages from your side.
Yeah, as a surgeon, one should choose the proper modality of treatment as per the surgical procedure is concerned. Either lobectomy or a Barrett's procedure or enucleation of the cyst should be taken into consideration after checking the size and site and location of the cyst. And as we know, rest all are the community measures which one has to take. That is there. But nowadays, a lot of meat making industries are there. The hygiene, we don't know from where the meat is coming. People are consuming it there. So there has to be some national program for these diseases. And if you can see, all these diseases are morely concentrated in the eastern belt of India, and the second is in the southern part of India. So these two belts should be highlighted for these two diseases, especially the Hydatid cyst and other parasitic diseases.
Thank you. Bhushan's role of surgical interventions is very, very important in Hydatid and other paragoniums Westermani. So the treatment of choice is we have to remove the cyst or sometimes lobectomy. We have to refer appropriately. So the take-home message is very clear from Bhushan's point of view. This is don't hesitate to get opinion from thoracic surgeon if you have any dilemma or any surgical cases. So definitely surgeon role is very great in the healing and curing completely the disease nature. Not only here, there is various aspects. Don't hesitate to opinion from the infectious specialist like Dr. Komal. Komal is a pulmonologist and infectious disease specialist. So don't hesitate to get the opinion from the other department. These are all the very important thing. And I have one question, chat box question. Dr. Syamal Sarkar from Jharkhand, Ranchi. What is hyperinfection syndrome? Diagnosis and treatment, please. Hyperinfection syndrome. Dr. Komal, can you take this?
Hyperinfection syndrome is a syndrome, I think, with the strongylitis.
Yes.
Strongylitis. In immunosuppressed people, especially HIV/AIDS, and those who are on high-dose steroids, where the worm infects the host itself, again with the same, like it need not be the external again, it is the internal this thing. It can be very problematic to manage. So that is why you are to be careful while you are giving steroid doses, especially when you are suspecting that there is a co-infection of this kind of worms. This is what I came across.
Strongylitis is unique among all helminthic diseases, that in it can multiply in the human host for so many years, for 10, 20 decades. it can multiply in the host itself. Doesn't have to go outside. So hyperinfection occurs in the immunocompromised persons, and because of this capability of the strongylitis, that they can multiply for decades in the human bodies. So they are everywhere in the human body. So because of this hyperinfection, they can multiply in the human body without from going exterior media. So this is hyperinfection.
Thank you, Dr. Kulbir and Dayanand, sir. And the final take-home message from Dr. Dayanand, sir. You can give take-home messages to the audience. Yes, sir.
All my peer have given their take-home message. My take-home message is like, don't forget the basics. Do remember where you are living. Your books may be telling what is there in the United States and UK, but have a knowledge of what is happening in the local thing. And when it comes to pet, I am a pet lover, but I don't have a pet at home. I used to have when I was a young boy, because my father was fond of pets. But losing a pet is very painful, And the lesson given to me by my father was treat it as a family member. So give the immunization, everything, treatment, whatever is there for the pet. So do take care of the pets also. And at the same time, be vigilant about the parasitic infections which can occur. So don't forget to think out of the box when you are not able to get the diagnosis for what a diagnosis you are thinking about, and things are not working out well. Think about parasitic infections also. That's my opinion.
One take-home message.
Yeah,
one take-home message that I want to give,
please,
that I earlier missed, that the difficult to treat asthma cases, we should always consider helminthic infection. Usually, I saw in a hospital today a child who was having infiltrates in the chest and wheezing, and he was taking all sorts of the Paracord from so many years. He was underweight, malnourished. So in the treatment of bronchial asthma, we should always keep the local area from where the patient is coming. We should keep helminthic infection besides in our mind while treating a difficult to treat asthma patient, because the cause of the disease is helminthic. The asthma, the cause is helminthic, and we are managing some other problem. So we should keep it in mind that helminthic diseases could be cause of asthma symptom seen in that child or adult. That's it.
Thank you, Kulbir sir. Thank you, Komal ma'am. Thank you, Bhushan. Thank you, Dayanand, for the wonderful discussion. I will learn so many things from well-experienced panelists like you about the parasitic lung infections. So I'll give my take-home messages from overall. So the respiratory parasitic infections is one of the important topic, our dream topic of our chairman, Dr. S Krishnakumar sir. So I hope sir's dream is fulfilled, but still a lot of things. So we have to learn a lot of things, and a lot of pipeline diagnosis and other modalities are available. So from the take-home messages, respiratory parasitic infections, any infection comes in, we have to have some high index of suspicious, and the differential diagnosis. One is included in the panel, like viral etiology and bacterial, mycobacterial, and fungal, include the parasitic infections in that infections part. So the history is very, very important. Where is the patient coming from? Already Kulbir sir told very clearly about that. Where is the patient residence? What's the occupation? What kind of food is eating? Whether hygienic or unhygienic? Whether eating food in the hotel? What kind of job? Is agricultural field? Is wearing the chapel or any footwear and all? This history and other cooked or uncooked meat is eating. So this history is very, very important. And meticulous examinations, because these parasitic infections can mimic various diseases. It mimics asthma, it mimics tuberculosis, it mimics malignancy. So you have to go for the clinical, radiological, microbiological, serological, and sometimes pathological. So mass lesion, diarrhea, the mass SPN, solved with nodule, excise and rule out any malignancy and all. So we have to go up to the, from simple clinical examinations to the excision of the mass lesion and lobectomy also sometimes. So the parasitic infections is one of the big spectrum of infective disease, helminthiasis and protozoas and various kinds of things. So we have to update our knowledges This is a wonderful. I learned so many things. Definitely, our audience will benefit a lot. So, any patients comes with infections not settling 1 week, 10 days time, with all negative, AFP negative, cytology negative, no malignancy. So we have to think in terms of atypical or this kind of rare parasitic. This is not a rare. This is not uncommon conditions. So among these, the Hydatid disease, amoebiasis, and then day-to-day practice, we are seeing left and right. So the high index of suspicious are very, very important, and the prevention is better than cure. Preventive protocol, and in the school health program, they are giving all the albendazole tablet. Yes, good. And the other hygienic aspect, there is a hand hygiene day is there. There are so many health days, so we have to give a lot of awareness. Awareness is the key in all aspects. So with this, I thank you very much, Chess Council of India and our chairman, Dr. Krishna sir, Nana sir, and the president, Dr. Ashish Dubey sir, and the national secretary, Dr. Anil Maske, webinar coordinator, Dr. Kumar Chetty, and the architect of this program, Dr. Atri Gangopathy, and Sivani ma'am, and our Kirat ma'am, Nitin, all the leaders, all the journal governors. So thank you very much for this wonderful opportunity. Again, we'll meet in other good occasion next Thursday. So, the one more important message I am going to give. Tomorrow is the World Sleep Day. I request everyone kindly spread the message across. This is also one of the important our CASM team. I wish everyone happy World Sleep Day. Tomorrow is World Sleep Day. I request everyone to do a lot of activities to update the awareness thing and all. So thank you very much with these our wonderful panelists. Thank you audience. Thank you CCI team and the technical team and the sponsors. So with that, we conclude this meeting. Thank you all. Good night. Long live CCI. Thank you very much.
Thank you.
Thank you, sir. Thank you.
Thank you.